So I offer them usually three options. One would be to do the non-surgical treatment, and I prepare them to have it every 3 to 6 months. Sometimes we don't need that, but I still say it's like a maintenance thing. We are not treating anything, we are stabilizing the problem. And with that, the advantage is that it's straightforward, simple, quick, quite cost-wise it's less than any other options. However, there is some inflammation going on, which is not the best for the systemic health, and it could flare up and get worse any day. So if they accept that, and if they want to go with non-surgical and multiple treatments, that's what we go for. The second thing would be a surgical approach to do augmentation and so on. If everything looks like we could keep the implant, and then that could be with or without implantoplasty. Again, we will talk about that. And then the other option would be to remove and start again. Remove and augment and start again. So that's the discussion I have with the patients. Most of them will say, okay, let's go with step by step, minimally invasive wise. Another discussion I need to have with that is that they might be kind of wasting money. We do the non-surgical and then the surgical, and then if we take the implant out at the end, of course, all these trials for nothing, but we can't know if we don't try. So that's if I see the potential, yeah. So always the cases where we don't discuss anything, I say this needs to come off. That's the truth. So what do we need to also think about is so here there are some also non-surgical therapies showing that there are sometimes also possibilities to control the disease with non-surgical approaches. And here we see that the Erbiumyag seems to be also working okay for that, and especially the microbiological and biochemical markers reduce even with just using the Erbiumyag. So that's an overview as an approach, but we still need to see if we can, when we decide about non-surgical and surgical, what will the excess be like. So depending on the implants, sometimes we have very active threads which go deep into the bone, and then if they are exposed, then it's very difficult to go under those threads without raising the flap. So are we going to be able to access the biofilm? And another issue with the access is the restoration. Sometimes we have quite small implants and quite large restorations on the top. Are we going to be able to go parallel to the implant, to go down to the depth of the pocket? So that's sometimes even difficult for probing, let alone treating around the implant with the lasers. So can we access without raising a flap? If yes, maybe it's an option, or that could be a reason to actually go for surgery. So if we are going with surgery, what are we doing with restoration? Are we keeping it on, or are we taking it off? Are we burying the implants? And what's happening as in the temporization period? So if you're burying the implant, if it's an anterior tooth, are we able to provide like a Maryland? Are they okay with the temporary removable denture? Is the denture a good option for a graft if you're grafting and so on? So these are all things we need to consider. And then the invasiveness, sometimes the patient had like 3 surgeries already to get the implant in, and 2 years later they already have this issue. Hopefully that wouldn't be my case, but I have a lot of referrals also which is like that, and it could be as well my case where they have short-term complications like that. 2 years would be kind of short-term for those cases. Again, cost could be an issue, but for some time is an issue. They would maybe prefer not to come every 3 months just because they can't, because they're busy and they don't want to come that often, and they might go with a more invasive solution to have more predictability. And of course, if the implant is not stable, it needs to come out. We cannot really help with these cases, even with the magic wand that our laser is. So cases like these, of course, we need to take things out and start again, educate the patient, and so on. So one case to show you, for example, a non-surgical approach. So this is a course that I was doing, a private course in Poland. 3 siblings, all dentists. They all have light workers and microscopes. And digital dentist and stuff, so really nice, fun practice. So this is what we do. It's really boring, quite straightforward, quite simple. Ideally, I would go normally with a radial firing tip, and step by step, we started without anesthesia and then the patient some pain, so we did it now, but later on. Sorry, yes, and there we go. And then we just go in, cleaning, as I mentioned before, thread by thread, 2, 1, 2, 1. That's again, now the 2-1 motion is for India mainly, to have a special fixed speed of movement, not to heat it too much or not to have too little heat. With this one, it's just there to make sure that I'm covering the whole surface. I'm trying to feel the thread, I try to go under the thread, over the thread, and the next thread, and the next thread, one by one, and then I kind of finish off with a vertical overlapping movement, because I have no visual feedback. In most cases, there is no calculus or anything like that that I see that's coming off. Sometimes there is, but mostly not. Sometimes there's cement coming off. But this is what we do. There is a photoacoustic effect. So when you're doing this, if you press or if you touch the buccal tissue with your finger, you will feel the photoacoustic effect very, very obviously. And that's it. So it takes about 7, 8, 9, 10 minutes sometimes that I'm just trying to go over this one tooth around the implants. I don't use the NDX, especially in cases like this. You see how tight the pocket is? So I'm actually even worried about the water going in there. So if you see a lot of clotted blood coming out, it's usually a sign that the water is not enough. So make sure that it's not coming off too much, because sometimes we think it's maybe calculus, but if you touch it, it's soft. So if you see a lot of black, dark, soft tissues coming out, it's usually showing that there wasn't enough water there. You see how deep this is? This is 14 millimeters tip, yeah? So we took our time with that. Also on the palatal side, same thing. You can see the mirrors there, thread by thread, up and down, mesiodistally. And then at the time they didn't have the biomodulation handpieces, so they were using the fiber for biomodulation. And also on the palatal side, every 2 days. And then this is upper right lateral incisor 5 years later. So you can see there is not much bone there. It's very concave and very thin phenotype, but there isn't any bleeding or pocketing. And the only reason we had a 5-year follow-up is because the patient came back after 5 years. Otherwise, I was planning to do a flap. So we have all these other options: citric acid application, chlorhexidine, antibiotics, hydrogen peroxide, air powder abrasives, photodynamic therapy, implantoplasty, and the laser itself. So cleaning wise, I think the one that comes close to laser is the air powder abrasive, and we will talk about that in a few minutes. So first, I'll go quite quickly through these literatures. Publications, because they're in your file, and it's just to understand the approach. You don't necessarily need to remember all of these. This here you can see they did a lot of different lasers, 4 lasers, to see if there's any heat. And at the bottom you can see sometimes the tube very short time, so 4.4 seconds to achieve a temperature that was too hot. You will review that. And if you check on that, I would ask you why that would be the case. So you see when there's water, it takes about 30 seconds plus on the spot to really heat it up. And that is quite safe, and in deeper areas, the temperature threshold was not reached. So some studies checking the fluids, and we know the smoother the surface, the shinier the surface, there will be more fluids to damage the surface. So a titanium plasma spray surface will need about 90 per centimeter square, which I will come back to about the settings to use. So every implant will have a different threshold for superficial structure damage. So ideally, I would suggest to ask for a sample from the company and then use the laser starting from 30 millijoules, 40 millijoules, 50 millijoules, up to 100 millijoules, just to check where you start to see some marks. But is that really important if we see some marks? Again, we will talk about that. So polished titanium, you see you can have up to 300 millijoules without any damage. But sandblasted acid etched implant surface, 100 millijoules is safe, 300 is not, so we tend to stay below 100 on the implant surface anyway. And we know it's safe. Again, 2 minutes of application, 60 to 120 millijoules. There is no heat, that's above 47 degrees, which is good. Again, another one says the temperature changes remain below 10 degrees. So it's quite safe about thermal side effect. But with this setting that below 100 millijoules, are we doing enough cleaning and disinfection and detoxification? That's the question. So that's when we see these studies that show 40 millijoules was removing the calcified deposits without inducing damage compared to mechanical therapy by cotton pad or titanium fluids. So it was more advantageous. It was removing the calculus better than the other options. With 40 millijoules only. Another one, checking with 30 millijoules, and they checked, what's that? A Biomet, 3i, Astrotech, Straumann, and Lifecore, and Nobel Biocare. Now, Nobel Biocare, the Ti-Unite, has this softer surface, and only that was damaged with 30 millijoules. And we know it's a problematic surface anyhow, so the issues go on with laser use. So all the others were okay with 30 millijoules, and it was again removing the calcified deposits effectively with that setting, 30 hertz, 30 millijoules. So they were checking up to again 100 millijoules, and they were checking the bone. So they were using the laser on the implant. They were measuring the heat on the bone contact area, and there was no issues again about that. So let's keep this not so important. Again, another one, 30 measures, 30 hertz, debridement of the implant abutment. So if you wanted to clean the abutment again, you can use this setting easily. Up to 100% of bacterial elimination with 90 millijoules. That's great, so we can also use this for disinfection. So that's quite interesting to compare the laser to the ultrasonic scale on the implant surface. So with the laser, the plaque was reduced to 0.03%. With the ultrasonic, it was reduced to only 11.7%. So the removal was much better with the erbium than the ultrasonic. Again, that could be either the direct ablation effect on the plaque, on the biofilm, or it could be also maybe stronger cavitation effect. So I don't know exactly, but either way, we have a full clearance of the biofilm of the implant.
Again, killing the biofilm bacteria, comparing curette and
In brushes, Erbium was better. And that was a common question I was asked, how many times we clean each thread. So they've shown that maybe 3 passages seems to be enough. So only 3 passages. I tend to do maybe 10, but 3 seems to be enough in this publication. Again, superior biofilm removal compared to Gracie curettes, photodynamic therapy, and combination of photodynamic therapy and curettes. So the Erbium with 30 millijoules up to 70 millijoules, but also with 30 millijoules, it was better than the others. Again, up to 98% plaque removal, 30 millijoules 10 hertz. 99.3% sterilization, disinfection without damaging the surface of the model in this one, so nothing on the bone. Again, the best method for decontamination of the implant surface is the use of air abrasives and Erbium laser. Yeah? So they check titanium curette, carbon curette, titanium brush, Erbium laser with different settings, ultrasonic scaler, and air abrasives. And then the best 2 were air abrasives and Erbium. That is to decontaminate, yeah, so to kill the bacteria. Now we know it's not enough to remove the bacteria to have a good healing around the implant. We have this thing that's called biocompatibility. That is also very important. Just as we discussed yesterday on the root surfaces, when we increase the biocompatibility of the root, we got faster fibroblast attachment, more blood cell attachment, and more fibroblast attachment. So it's important to also check the biocompatibility. And then I saw this literature. So this isn't anything to do with the letter. This is a literature review on air abrasives. And the conclusion said removing contamination without damage was possible with air abrasives. The main drawback of the air abrasive method seems to be its limitation in restoring the biocompatibility of the surface. So that's coming from that literature, nothing to do with laser. Then we go back to the laser to see how biocompatibility is on the implant surface. So here we have 60 millijoules.